Hello, everyone, and welcome to today's webinar. My name is Yeshua. I'm the Social Media and Outreach Coordinator at the Canadian Cancer Survivor Network. On behalf of CCSN, I'd just like to thank you for attending today's informational webinar on anal and colorectal cancer. If you're new to one of our webinars, let me just take a moment to give you a brief overview of our organization. The Canadian Cancer Survivor Network, or CCSN, is an organization working with cancer patients and survivors to learn about the complexities of our health system, connect with others to plan action, and act on those plans to promote better healthcare and healthier survivorship. So if you'd like to learn more about CCSN, please visit our website at survivornet.ca. And you'll find plenty of information there on us, as well as news, events, and other resources that we think you'll find helpful. I have two quick announcements before I hand things off to our presenter. We just want to let you know that this webinar is being recorded and it will be available on YouTube as of tomorrow. The video link will be sent to the email you provided when you registered. So you can share this resource or go back and watch it again if you'd like once you get that email. At the end of the presentation, we will have a short Q&A session. However, don't feel the need to wait until the end. Please feel free to type your questions into the window at the bottom right of your screen so we can have them queued up and ready to go. So with that said, CCSN is pleased to welcome our presenter, Helene Hutchings. Helen is a highly active cancer advocate, particularly in the area of anal and colorectal cancers, where she's also a founder and CEO of ABUMRAP, a group dedicated to anal and colorectal cancer. Additionally, Helen is herself a cancer survivor, having been discharged from the care of her colorectal surgeon in October 2013 and radiation oncologist in September 2014, respectively. So now it's my pleasure to pass the floor to our presenter, Helene Hutchings.
Thank you so much, Yeshua, and thank you so much to the Canadian Cancer Survivor Network for having me on today. Again, I've been doing this for several years, and so I'm going to go through the slideshow. A lot of the things I'm going to talk about are on the slides, but I'm also going to touch on other things which come about as a result of the things that are on the slide. So as Yeshua said, I am going to speak about colorectal, but mainly anal cancer on this webinar. And if you do have any questions, and please feel free to type them in and we will answer them to the best of my ability. The things we're going to be discussing today are, who we are, anal cancer, ABUMRAP, and then understanding colorectal and anal cancers, mainly the differences, risk factors, symptoms, treatment options, prevention, and then a question discussion at the end. I want to say that we are so blessed to have some absolutely remarkable peer support groups nationally and internationally. I do want to mention the Colorectal Cancer Canada. These are a phenomenal group who predominantly support colorectal cancer patients, but they also have phenomenal information on anal cancers as well. And they usually will, ask for my help and advice if they get anyone approaching them with the anal cancers, just because we're a slightly bit different from the colorectals. And then anal cancer, ABUMRAP. Who are we? So we are all volunteers, either past or present anal cancer patients. We're based in Canada, but we provide international support, not just through Anal Cancer ABUMRAP, but I'm also a moderator on some phenomenal international anal cancer support groups who are headquartered in the US, but we serve the English-speaking global anal cancer patients. What we try to do is promote the international awareness and education of anal cancers, as well as providing support for patients and their caregivers, because it's really hard on the caregivers as well, especially for anal cancers, and because the treatment for the anal cancers can be so extremely brutal that it's hard for caregivers to watch their loved ones go through this. What we do is we advocate for primary prevention, screening, and equal and timely access to effective medications to improve patient outcomes. So we're always trying our best to keep on top of, you know, treatments, both conventional, integrative per se, but more so the clinical trials and things, treatments for patients where conventional treatment has failed them. One thing I want to comment on most importantly is that we are not medical professionals, so we do not give advice that is to be perceived as a medical advice. I really want any anal cancer patient and their caregivers to really feel comfortable in the knowledge that they are in the hands of a superb medical team, because it does take a medical team to help anal cancer patients through diagnosis, treatment, and then the after effects of the pelvic radiation that we receive. So loving your medical team is very important in my opinion. So when it comes to understanding the colorectal and anal cancer, so, you know, what are they? What are the stages, the symptoms, the risk factors, and then the vague numbers or approximate numbers within Canada for these kind of cancers? And there's several different types of colorectal and anal cancer. And one of the things that I think is really important when it comes to anal cancer, there's a huge stigma in the word anal. And a lot of our patients and our, you know, members of our international groups, we have around 1,000 members. So we pull in information and commentary from more patients than most colorectal surgeons will ever get the opportunity to deal with in their lifetimes. Luckily, because anal cancer is a rare disease, colorectal not so much. But because we have our finger on the pulse of around 1,000 anal cancer patients worldwide, and they're just the English-speaking ones, it means that we realize very astutely and acutely how much stigma is involved. So I really want everyone to get used to saying colorectal and anal cancer instead of saying just colorectal. March is Colorectal Awareness Month in North America. I want that changed to Colorectal Anal Cancer Awareness Month, just so that the anal cancer patients don't feel further stigmatized by the fact that the word anal is not used, and therefore if you whisper a word or don't use it at all, it makes patients feel even more embarrassed and stigmatized. So what is colorectal and the anal cancers? So as you can see from the slides, I've got diagrams that tell you roughly what the colon and rectum is. It's otherwise known as the large intestine. It's approximately 6 feet in length, and its function is to reabsorb water from the digestive contents, and it serves as a holding chamber for stools until evacuation. So stool is the polite word for poop, and we will probably be using the word poop throughout this because hardly anybody uses stool or feces per se anymore. And then the anus is the opening at the end of the large intestine through which the poop exits the body, and the anus region includes the anal canal, which is approximately 4 centimeters long, and the anus. The colorectal cancers, and there are several types, are the cancers that affect the colon or the rectum, and known as cancer of the large intestine or the large bowel. As I say, there are several types of colon or rectum cancers. And then most colorectal cancers start in the cells that line the inside of the colon or the rectum, and typically they grow slowly, and it's curable when diagnosed early. Advanced colorectal cancer is when the cancer has grown through the entire colon or rectum wall and into nearby tissue or organs. So then it's a case of, well, if that's colorectal, what's anal cancer? So anal cancers, and there are several, is a cancer that affects the area that marks the transition between the rectum and the anal canal, or the anus. And it can affect the anus and the anal canal, or the anal canal and the transition zone. And as I say, there are a variety of them. And the prognosis of most of them is better if caught in the early stages. Tumors of the anal margin, which is below the anal verge and including the perianal hair-bearing skin, are classified with the skin tumors. So there's a differential between a skin tumor and an anal tumor, which is up within that anal canal area. So your medical team will be explaining to you what you have if you are diagnosed with an anal cancer. And I think one thing I want to touch on is the embarrassment factor of having anal cancer and how the last 2 years of COVID has further exacerbated and enhanced the fear and embarrassment that a lot of patients have of going to their initial doctor visit for anal cancer. We know from what we're hearing from members that there's been the fear of going into the hospital because of the COVID, there's the coupled with the embarrassment. And so we know that unfortunately, a lot of patients with anal cancers of any type have a tendency to delay seeing their doctor because of the embarrassment factor of it. And what I'm going to say to those of you who are listening, be you both medical professionals and all the patients themselves, I understand the patient's embarrassment, I really do. But if I was to put a white coat on and be your colorectal surgeon, then the most important thing for me to do is to help save your life, enhance your life, extend your life. And even though it is your bottom that I am looking at, I want you to know that I am not embarrassed about this. I want to help you. So that's me with a white medical coat on if I was a doctor. And from a patient point of view, sometimes what we try to sort of joke with our members about is, let's just pretend that the anus is your mouth and you go and just, pretend your mouth is your anus and you're really embarrassed and you've got your COVID mask on and everything else, but your bottom is just your mouth, and pretend you're just going to the dentist. You would not be embarrassed. And so that's an important thing I want to comment on. When it gets to stages of the different cancers, the colorectal cancer, they have a tendency to upgrade staging nomenclature quite regularly. So all of this information can be found on excellent online sites from the large hospitals, both Canadian and American and others. But the stages of colorectal cancers are stages 1, 2, 3, 4, and you can see on the web page that you're seeing what the differentials through those are. As I've said before, the earlier you get diagnosed, the better it is as a vast rule. So any concerns that you have about your tummy or your bottom, then please try to go to the doctor soon. The stages of anal cancer are, as you can tell from this very squishy slide, there's a lot to differentiate the stages of the anal cancer. The stage 0, if I would say that the vast majority of anal cancer patients, and I'm predominantly going to be talking about the squamous cell carcinomas of anal cancers. As I've mentioned before, we have quite the plethora of anal cancers, both squamous, cell carcinoma, there's adenocarcinoma of anal canal etiology, there is anal melanoma, there is anal neuroendocrine cancers, there's anal sarcoma, there's just this huge amount of cancers. Some people are actually diagnosed at a super early stage when they've got precancerous cells that are only in the mucosa. This is classified as stage 0 or carcinoma in situ. And this is typically called anal intraepithelial neoplasia. And this is very I'm not going to say common, it's very similar to cervical intraepithelial neoplasia. This is predominantly the 99+% human papilloma virus related cellular change with or without the presence of genital warts. I think everyone thinks human papilloma virus and then visualizes that the patient is going to have anogenital warts, and that's far from the case. And also I would hasten to add that the vast majority of genital wart cases are caused by the non-cancer forming human papilloma virus strain, of which there's very many, but we all know there can be the cancerous strain lurking underneath the benign warts. So there's all these stages, and again, if it's caught early, great, but even if you're late stage, it does not mean the end of the world as you know it immediately. We have some stage 3C and stage 4 anal cancer patients who have survived 5, 7, 10, 15 plus years at this stage, and medical treatment is getting better and better. Thank goodness for research, and you know, there's always hope. So remember that. And when we talk about what would take you to the doctor, why would you go? What is it that's happening to your body, your tummy or your bottom, that's making you feel concerned? So when it comes to symptoms of the colorectal and anal cancers, symptoms may not be present in early stages, and in fact we have some late diagnosed and late stage anal cancer patients who have no symptoms whatsoever, and it was just a random find on a colonoscopy or something. So symptoms may not be present in the early stages, and if or when symptoms appear, they'll vary depending on where the cancer size and the location. And I have to state that the most common misdiagnosis in anal and some rectal cancers I have to comment on is that the patient and or the primary care physician, GP, thinking that the cancer is just hemorrhoids. And if I had $100 for every time I dealt with an anal cancer patient, predominantly with adeno or squamous cell carcinoma, who was misdiagnosed with hemorrhoids for the first 12 months, 18 months, 2 years, I would be a multimillionaire at this point. Now, what that means is that we need to do a huge amount of teaching, advocacy, bringing people to the table to make them aware of when is a hemorrhoid not a hemorrhoid. And there are organizations who, you know, we do have talks on this because it's just the most common misdiagnosis. And the patient's already embarrassed enough going to the doctors about hemorrhoids, and then the doctor hasn't really realized that it's not hemorrhoids, and they get sent away with hemorrhoid cream. And of course, the hemorrhoid cream does nothing, and the patient's really embarrassed because they're thinking they're feeling a bit, you know, embarrassed, and in some cases, unfortunately, maybe a little bit belittled to thinking, oh, it's just hemorrhoids, and it doesn't work, and they don't go back until, you know, things are getting so bad that they have to go back. So when is a hemorrhoid not a hemorrhoid? When it's anal and or rectal cancer. So every patient and doctor needs to be aware of that. The risks of the colorectal cancers, as we know, age is one, a patient's history of polyps, cancer, or inflammatory bowel disease. And the reason inflammatory bowel disease is one of the risk factors is because we know that if you have chronic inflammation over years and decades, then there is going to be a point where the cells that are having this inflammation constantly at them, in them, are just going to one day potentially change from being a normal cell to a abnormal cell, which may well then change to be a cancer cell. Family histories of colorectal cancer, the genetic syndromes, racial ethnic background does play a part, and lifestyle related risk factors. Now, all of these things can be looked at on Dr. Google. Be careful of too much Dr. Google. Please try to go onto the bona fide hospital sites to find out all the information that you need to know, and your medical teams will also provide you with excellent data. When it comes to risk factors of anal cancer, there are several factors which may increase the risk of developing the most common type, which is the squamous cell or epidermoid carcinomas. And these include age, frequent anal redness, swelling and soreness, inflammatory bowel disease, having anal fistulas, which are abnormal openings in the anal area, lowered immunity, so people living with HIV or organ transplant recipients or are on immunosuppressive drugs for a variety of reasons. Human papilloma virus infection is a known factor, and as I say, this is with or without genital warts. The vast majority, I would say, of people in our groups who have HPV positive squamous cell carcinoma have never had a history of genital warts. So, but it's one of the stigmas. Having multiple sexual partners, well, how many people does it take to have sex with to get pregnant? One. How many people does it take to have sex with to get HPV? One. You can have sex 1,000 times with the same person, and you don't have to be sleeping with numerous people. It just enhances a risk. Having receptive anal intercourse is a factor, and this is one of the big stigmas, again, that we deal with a lot on our anal cancer forums. The majority of our members are heterosexual, female, non-HIV women who are, I would say, our most common age is very late 50s to early 60s, which is lower than the average age they put on the statistics. And we also have a huge amount of below 40. So between 38 and 50, we have a lot of ladies who have anal cancer. And the whole connotations and the stigma with the word anal and HPV, and everyone is assuming that they're having anal sex. And the biggest thing I'm going to say about that is if anal sex was the reason for anal cancer, then we'd be having a global pandemic, because anal sex is one of the biggest taboo subjects there is as well. And there is more people having anal sex than you think, because people don't talk about it. It's a risk factor. It doesn't mean that your anal cancer patient has been having anal sex, and even if they have, then it's not the be-all and end-all cause. Smoking cigarettes is another risk factor. A lot of these risk factors are the same for a majority of cancers. And then you get the people who have no risk factors at all, and they'll still develop anal cancer. And this type of anal cancer, as I say, is rising significantly amongst heterosexual HIV negative women. And I've touched on the other anal cancers before, the adenocarcinomas, melanoma, lymphoma, neuroendocrine, and the sarcomas. Colorectal cancer rates in Canada in 2021, there were nearly 25,000 Canadians will have been diagnosed with colorectal cancer. It's affecting men and women almost equally. And screening rates are still low despite provincial screening programs. So I will emphasize the fact that I know that lots of people do not want to go for colonoscopy once they're over the age of 50 because they're embarrassed, they don't want to do it, but you know, just go for it, just do it. The medical team who help you are so stupendously understanding and discreet, and they really respect you as a human. So, you know, it's not as bad as your mind is making you think it is. And especially if you have symptoms, you must please go and be screened. And, you know, even if you're having weirdy symptoms like the stomach bloatings, the poop that looks strange, then, you know, please go to see your doctor. And if your doctor's sort of may or may not be, in your perception, shunning you off, then demand. Sometimes you have to be the squeaky wheel, I'm afraid to say. So anal cancer in Canada is classified as a rare disease, and there were approximately 585 cases in 2016, and believe it or not, we don't have any more updated stats for that. In the United States, the estimates for 2022 are approximately 9,500 new cases, and interestingly, 2/3 of those cases being female. And this is because, as I say, we're seeing a definite rise in the number of heterosexual females being diagnosed now with anal cancer. So it has to be on the radar for a lot of the primary physicians that this is going on. Anal cancer numbers are also high amongst the men having sex with men and the HIV positive population, specifically the squamous cell carcinomas. And as I've said before, 80–90% related to human papillomavirus. Number of new anal cancer cases has been rising for many years. You can find these statistics online, maybe not so much in Canada, but you can in the States and elsewhere. It is rare in people younger than 35, though we do have some members who are in that 35 to 40 age group. And it's found mainly in older adults, with an average age being in the early 60s. As I've said, I think we have a huge amount who are in between 40 and 50 on our groups. And it's also more common in white women and Black men. So there's all these links that you can go to find out more information. When it comes to treatment options, there's the surgery, chemotherapy, radiation, and then the biologics. And you have to, as I keep reiterating, please trust your medical team. Hopefully you've been introduced to a medical team which will probably consist of a colorectal surgeon, a medical oncologist, a radiation oncologist, and they're related, you know, the wonderful nurses and the wonderful radiation techs and all of those amazing people who are there to help you, you know, save your life and enhance your life. And hopefully you feel really comfortable with them. You may not feel comfortable with them from the get-go, but, you know, hopefully that will come, because you have to feel safe with your medical team, and you have to trust your medical team because you're putting your life in their hands. And so that's where the trust comes in, and it will also help you feel better if you feel healthier with that. Surgery remains a primary treatment for the colorectal cancers, and it may well be an option for the anal cancers. So in the very early stages, the surgeries can include removing a polyp during a colonoscopy, or in the case of an anal cancer, a small lesion can be removed if it will not impair sphincter function. So what the colorectal surgeons will do is really analyze whether they feel that they can safely remove a ultra-low rectal and or a anal canal, anorectal transition line, anal canal, anal verge tumor, and not make you incontinent. So that's one of the big things that the surgeons will really analyze, because what they don't want to do is, you know, remove something and then make your life pretty hell afterwards, because fecal incontinence, urinary incontinence, fecal incontinence is awful to live with, and we have a lot of members in our groups who are living with the effects of fecal incontinence. And I will tell the physicians now that emotionally it is a utter nightmare. It is a huge life draining position to be in, and we unfortunately have many members who do not go out of the house. And I think it's absolutely dreadful in this day and age that their medical teams have allowed such a thing to happen. So I really strongly advise medical teams to be talking to their patients about their function post-surgery, post-chemoradiation. So in the advanced surgeries, such as I said colectomy, I meant a colostomy, a section of the colon rectum can be removed. And in the case of anal cancer, if that has to be the case, then typically advanced surgery includes the removal of the lower part of the rectum and the anus. And for a lot of our female members, that has also meant vaginal reconstruction surgery, because a section of vaginal walls also had to have been removed. So we do have a lot of colostomy anal cancer members in our groups. We have numerous subgroups in our online forums. So the general group, we have a stoma group, we have stage 4 metastases group, we have clinical trial groups, we have groups just for men. So we have all these groups to help people deal with whatever surgery they're having done. And then going back to the surgery slide, and if possible, the remaining parts of the colon and rectum are reconnected to create a functioning colon, or a stoma is created. So the removal of the anal canal and the anus will result in a permanent stoma. So that is very much a given for that. And it's usually a case of last resort. When it comes to the chemotherapy radiation, so anal cancer, for squamous cell anal carcinoma, and typically for the adenocarcinoma as well, the most conventional treatment is chemotherapy combined with radiation therapy. So what the chemotherapy is trying to do is stop the growth of the cancer cells, either by destroying them or stopping them from dividing, and it can also be used to reduce the size of metastasis, because the chemotherapy goes through all of your body. So if you do have metastases, all the colorectal anal cancers all have a tendency to metastasize to spine, liver, lungs, sometimes the brain, if you're unfortunate enough to evolve into stage 4 cancer. So the chemotherapy does that, and then what they also do for the anal cancers, and typically for some of the ultra low rectals too, is they'll do radiation therapy as well concurrently. So the radiation therapy damages the genetic material within the cancer cells and limits their ability to divide. Normal cells are affected by the radiation as well, but they're able to repair themselves in a way that most cancer cells can't. Radiation is, as we lovingly call it, the gift that keeps on giving. And so I finished my radiation treatment in 2010, and it's now 2022. I'm 12 years, no evidence of disease, but I still have the effects of the pelvic radiation treatment. So we're going to talk about that later as well, because that's another really important thing that I want to talk about. The biologics are the immunotherapies. And so phenomenal research going on worldwide, absolutely phenomenal research going on within Canada itself, which I am so thrilled that it's happening. So what are the biologics? They're sort of man-made versions of an immune system protein that fits like a lock and key with a particular protein. So they'll lock onto cells or proteins and stop activity, which helps stop the cancer cells from growing and dividing. And then they're called personalized medicines, and they identify genetic differences in individuals that affect the way people respond to drugs. And it's done through identifying biomarkers, biological molecules found in, like blood, body fluids, tissues, or the tumor itself. And it's absolutely cutting edge cancer research, which is evolving every single year, I am thrilled to say. Usually, most anal cancer patients, they will be placed on the conventional treatment first, which is called the NIGRO protocol, NIGRO, chemotherapy radiation protocol. And if that fails them, then they may proceed to yet another chemotherapy style, but a lot of them are going straight to clinical trials. So they're going straight onto the immunotherapy treatments. Some of our Canadian members are actually having treatment via the United States because it wasn't available in Canada yet, or as easily. So all of these things you can discuss with your oncologists, which are going, and they'll tell you, what's going on, what the processes are, how to find clinical trials if that's what you need. And we have clinical trial groups in our patient forum so that we can help people also with that search. When I was talking about the fact that I'm now 12 years after my chemoradiation treatment for my squamous cell anal carcinoma, which was up at the anorectal dentate line, so it was higher in the anal canal, I had surgery first, which removed my tumor, which was 1.9 centimeters approximately. I was a stage 1, so it hadn't spread to lymph nodes, it hadn't spread to the local area, and no metastasis. But the margins of my tumor removal had microfoci of squamous cell carcinoma in the margin. So I went forth and had the chemoradiation following my surgery. And the chemoradiation treatment for anal cancer, there is no kind words to say what the treatment is like for anal cancer. It is brutal, it's intense, it is painful. I would say that the vast majority of patients find it extremely painful. Pain is soul destroying. So as we know, if your patient is in utter pain, the energy that the body has to use to even try to cope with those horrendous pain levels means that the healing and the transition through treatment is hampered. So really good pain management is really, really important. And I would say that from my experience of being on online help forums now for over a decade, that pain control is vitally important, and some patients are not getting it. I don't know what some doctors are thinking. Maybe they think, you know, it's like pain on your finger or pain on your arm or pain on your chest, or it's totally different. There are two of the most sensitive parts of your anatomy are your lips on the mouth and the anus. Those are the two most highly sensory areas. So the pain felt in those areas with the brutal treatment that the chemoradiation gives is acute, and therefore it needs managing well pain-wise. So the radiotherapy radiation is super highly effective in the treatments of most of the anal cancers, and there's been huge improvements in radiotherapy technique and equipment over the recent years. But because of the very nature of how the radiotherapy works, it affects the tissues and organs in the pelvic region. And what happens after the treatment is done, and the treatment has worked, as in the tumor has been annihilated, you get what's sometimes called late effects, although some symptoms may occur at any time, from during treatment to many years later. And these include the sexual function issues, including vaginal stenosis, anal stenosis, erectile dysfunction, bladder issues, joint pain, especially in the lower back, hips and upper thighs, rectal anal bleeding, and loss of fertility in women. I think all these points are something that, another thing I have to really drive home to both any patient listening, any medical professional listening, is that these after effects are very, very real. And North America has a bit of a habit of shoving them under a carpet, unfortunately. The best research in this is being done in the United Kingdom, and there's a phenomenal website called the Pelvic Radiation Disease Association in the UK, who are absolutely phenomenal studies being done, research, clinical trials for, you know, how to deal with late stage pelvic radiation, the vaginal stenosis. You know, these things are manageable when they're managed from the get-go. A lot of medical professionals aren't speaking to their patients, female patients, pertaining to vaginal physiotherapy that is to take place either during, but especially after pelvic radiation. The anal stenosis is affecting both our male and females, and obviously for our male homosexuals, where anal sex is an extremely important part of who they are and their way of being intimate with their partners, the anal stenosis is also a problem. And also be talking to your male patients, homosexual patients, about the pros and the cons of being able to have anal intercourse post chemoradiation for anal cancers. The bladder issues are huge, incontinency. The joint pain is particularly severe, especially in the first couple of years, I would say. And the radiation also has a tendency to lead to osteoporosis. So you've got to be aware that these things happen. And if you're not reading up about it in North America, just look at the UK information. It's there. There is absolutely zero excuse for any medical professional to say they don't know. No excuse whatsoever. So the loss of fertility in women is predominantly because the women are predominantly, you know, late 40s, 50s when they're being diagnosed with anal carcinoma. If they're in their mid 40s, then I was 43 when I started treatment. So the chemoradiation puts you into instant menopause. So this is something also that has to be discussed with your patients, and the pros and cons of ovarian relocation. So, you know, if you have a really young 36-year-old anal cancer patient who has to have pelvic radiation, then, or ultra low rectal carcinoma female, then the ovary can be relocated higher up the abdomen, so it's not affected by the radiation. There's all these things that you really should be thinking about. I know that many of the oncologists, it's a case of they're concentrating on our life and death. They're not really thinking of our long-term effects or our fertility or things like that. But it's important and it needs to be spoken about. When it comes to trying to prevent colorectal cancers and anal cancers, this is sometimes a difficult one. Yes, there's screening, there's the healthy lifestyle, the human papillomavirus vaccination, which is HPV causes a myriad of cancers, not just anal. It's causing the anogenital, head and neck, and I'm sure as time goes on and more research is done, we're going to be finding that that delightful HPV family cause more than we even know they're causing at the moment. And then the benefits of peer-to-peer anal cancer support on the emotional well-being of patients. So in the colorectal cancer screening, we've talked about this, age of 50, you do the fecal occult bloods or fecal immunohistochemical test, which is really superseded everything now and is the one you should be having at least once every 2 years. I know many people don't have it done, but really I really think it's worth you doing, so please do. And obviously if you have any symptoms at all, bleeding, your poop looks weird, it looks like a ribbon, or you're having difficulty pooping, or your poop is really strange colors, then you just go see your doctor. A high-risk person for the colorectal cancer screening is if you have a family history of the colorectal cancers, that's a first degree, parent, sibling, or child. And then you really need to start maybe earlier. In fact, I would say definitely earlier. They usually say 10 years before your first degree relative was diagnosed. So if you had someone diagnosed at 53, then you would start screening at 43. And as I say, any symptoms, you just go and do it straight away. So anal cancer screenings, there's no national guidelines for the general population of anal cancer screening. And at present, it's mainly carried out for what we're considering as our high-risk populations, which are our organ transplant recipients because they're immune suppressed, our HIV positive patients because they're immune suppressed, men having sex with men, or past anal cancer patients. So screening includes a digital anal rectal exam. I'm going to say that a primary physician can do this, your gynecologist can do this, and it is simple test. It's I'm not necessarily going to say that it's the most pleasant experience in the entire world, but it certainly doesn't hurt if it's done properly and with care. But a digital anal rectal exam is amazingly good for picking up tumors and things. High resolution anoscopy, obviously having a colonoscopy that actually looks at the anal canal as well, doesn't just go straight past the anal canal and doesn't look at it. Every single colonoscopy doctor now is doing that. Anal PAP and HPV testing. So anal PAPs is exactly the same as having a cervical PAP. So not that many places will do it. It's a little bit more complicated, but it's that way, and HPV testing to see if we've got the cancer-causing HPV strains. And the precancerous anal neoplasias can be treated at this stage. And as I said, the anal neoplasia is similar to the cervical neoplasias. I would also comment that a huge amount of our heterosexual female anal cancer members with the squamous cell carcinoma have had a history in their 20s of cervical dysplasia. So they've had CIN 1, 2, 3. CIN, cervical intraepithelial neoplasia, is 99.9% HPV related. HPV is so common, it is stupendously common. It's waste time being embarrassed or allowing it to be stigmatized because it's so common that it's something important to know that if you have a patient who in her 20s had cervical intraepithelial neoplasia, then it's a risk factor that, you know, 20 years down the line, that patient may be at high risk of having anal neoplasia. And if you can pick up the neoplasia early, then you may help prevent that woman going forth to have stage 1 or 2, 3, or God forbid 4 anal cancer. So preventing colorectal anal cancers, healthy lifestyle tips, and I'll keep reiterating that sometimes just we have no idea why people get cancers sometimes. There's no risk factors, there's nothing, and it's just bloody hell, it's just bad luck. And so, you know, all these tips of what you can do is great, But even if you did all these things, doesn't necessarily mean that you're never going to get a colorectal or an anal cancer. But maintaining a healthy weight, moderate exercise, your diet, eat more fruits and vegetables, depends what you believe in. I personally am more carnivore, so I don't eat tons of fruits and vegetables and whole grains and lean protein, etc. So limiting alcohol and red processed meat consumption. As I say, I'm 12 years no evidence of disease and mainly red meat carnivore. And stopping smoking. Well, we can all tell everyone to stop smoking. That's a good idea. You obviously always have to speak to your doctor before engaging in physical activities and discuss with them the HPV vaccination to see whether it's good for you. Now I'm going to come to the benefits of peer-to-peer support for both colorectal, for all the colorectal anal cancer patients. And there are amazingly brilliant international peer support groups online. And every patient is different. Every member is different. I didn't want to join a peer support group until I was 3 years out of my cancer treatment. Other people come to us on their day of diagnosis. They haven't even started their journey yet. So everyone's individual, so it depends on how you feel. But in addition to the advice and support of your medical team, and I keep reiterating how important that is, you have to trust your medical team. There's nothing wrong with you also doing all your own analysis and research. These days, it's even easier to do a lot of research, but you have to trust your medical team that they're doing what's best for you. So the availability of support from cancer patients, from other cancer patients who've had the same similar cancers as you is so extremely important, especially for the rare and highly stigmatized cancers such as anal cancer. And as I say, there's so many support groups out there, and I would say the vast majority of them are absolutely superb, and they offer emotional support, advice for dealing with the treatment side effects in the short and the long term, information on clinical trials. And we have specific anal cancer support organizations, there's specific colorectal cancer support associations. So you can contact me for more information on any of those, but it really does help. We find that it gives, especially for the anal cancers, when these patients come in and they're shocked at a diagnosis. Anyone is shocked when they're told they have cancer. There's no getting around that. But it's added shock when it's anal cancer because of the whole stigma around it. We have members who don't even mention the word anal, ever. They'll say they've got colorectal cancer. And that's because of the stigma around anal. So we need to start using that word more often. These are a few testimonials. I'm not going to read through them, but it's just to reiterate, what is it that helps a patient when they come into a group of 100 or so, 200, 300 people who've walked their journey. And, we've walked through the shame and the stigma and the embarrassment. And so we understand where these newly diagnosed patients are coming from, and we bring them in and we support them through what is one of the most awful periods of their life. Anyone who's told they have cancer knows that. So we advise and support, tips and advice, things like, make sure you're taking someone with you to every single doctor's appointment, which has been a nightmare in this COVID 2 years. So people have had to FaceTime with their, support outside in the car. It's been awful and horrendous. And I know it's been awful on patients as well as the medical professionals, because as I've said before, your medical professional is wanting to help you, save your life, enhance your life. And they've known how horrendously difficult it is for an individual to have to come into a cancer center all on their own, to be told of a diagnosis and treatment. And we all know that, sometimes you'll sit there with your patients and you'll tell them the preliminary diagnosis, and their eyes have glazed over from that point because they can't take any more information in. They are in utter emotional overload, which is why patience and care and sympathy, you may not be able to be empathic because you're not had anal cancer, but it's all of those things that you have to provide. And again, it's important because you hear about different treatments that work for other people. So if conventional treatments failed you, we have groups who've gone on to the next form of treatments the clinical trials, the immunotherapies, and it's all of those things. And in our groups, we talk about anything and everything. We're not embarrassed. We're going to talk to you about the pain, how to poop through the pain in a sitz bath, vaginal physiotherapy, the issues with sexual dysfunction at the end, the pain, emotional and physical, and how to deal with family, how to deal with the people who don't talk to you all of a sudden because you have a cancer diagnosis. It's all of those things. Anal cancer is so rare that it's just important sometimes to be within a group of people who can really help you with that. So as I said in the beginning, March is Colorectal Anal Cancer Awareness Month, and we really need to get that word anal out there. The 21st of March is an internationally recognized Anal Cancer Awareness Day now, and as I say, we're globally increasing in numbers, but it's one of the least talked about and the most stigmatized of all cancers. Now, remember back in the day, we never mentioned the word breast cancer either. I worked in pathology back in the 80s, and you know, back then there were still women who wouldn't use that word, let alone cervical, vaginal, penile. You know, we've got to get these words out into the open to lessen stigma, to allow our anal cancer patients to come forward with their symptoms, and so not feel as though they're having the embarrassment to talk about. We've got to talk about it. We've got to break the silence. We've got to lose the stigma. And as I say to a lot of people, please do not die of embarrassment, because if you don't go to see the doctor and you do have anal cancer or the colorectal cancers and you don't go and see anyone, then that's not good. So that's the end of my little talk. I hope that you've gained something from it. And now we're in our sort of question and answer period, and I put that up on the slide just so that you know it's there. But yeah, does anyone have any questions? I seem to have lost my camera look, but never mind.
Awesome. Well, thank you so much, Helen, for that amazingly informative presentation. We have gotten a number of questions over the course of the webinar, so I'll bring them up here. I'm not sure if you can see them on your panel.
I don't think I can. Let me.
We have Deborah here asking. She was wondering if it's recommended to have a bone density scan. I'm going to assume she meant scan. Yep. After having anal cancer treatment.
Yes. So anyone who has had pelvic radiation, which is what you get with anal cancer treatment, and some of the rectal treatments as well, and gynecological radiotherapy is pelvic radiation, we're actually entitled to a bone density scan every 12 months. So your doctor may not know that, but that is the proviso. So I have bone density scans every year now. So yes, please ask to be referred for your bone density scan, because radiation, pelvic radiation, does have a tendency to mooch on to osteoporosis, even if there's no history of osteoporosis in your family and regardless of age. So I was only 43 when treated. So I have clinical osteoporosis. I don't take any medication for that yet, but I am under the guidance of my medical specialist, because I actually still do see my gynecologist once a year, who's part of my cancer treatment team. I see my colorectal surgeon once a year. Still, I started seeing him annually again after year 7. And I actually see my radiation oncologist once a year now, because he is specializing in late effect pelvic radiation. And so because I'm a 12-year no evidence of disease pelvic radiation person, I see him for skin effects. So what, as I joked, radiation is the gift that keeps on giving. And so we live with that. Okay. I hope that answers that question.
Yeah, that's great. William here is saying, I have prostate cancer with lymph nodes, cancerous as well. Do I go to my family doctor to discuss anal rectal cancer testing kit?
So prostate cancer is a utterly and totally a non-related cancer to any of the colorectal or anal cancers. But I am going to say, William, if you have concerns, then please go to your family physician and ask him or her, ask them to give you an exam, a digital anal rectal exam to begin with. And if you have more concerns, you know, write a list of everything that's concerning you. And if your primary care physician feels that it's beyond their scope, then they will refer you to have a colonoscopy or something like that. As William told us how old he is by any stretch of the imagination. Okay, so William, I know that prostate cancer can affect men from a young age to a much older age, and I already know that you will be under the care of a superb medical team for your prostate cancer with lymph node involvement. So speak about your concerns to them as well, because your prostate cancer specialist will also know who to send you to for concerns anally and rectally.
Another question regarding potential prostate cancer is, if HPV can cause rectal and colon cancers, can it also cause prostate cancers?
So as far as all the studies I have read up to now, and when I worked in cellular pathology way back then, I actually did my thesis on human papillomavirus as a cause of cervical carcinoma, would you believe? I'd say no, that at this moment in time, there is absolutely no correlation between human papillomavirus and a prostate cancer. Please do ask your specialist, because believe me, they will be reading as many scientific papers that they possibly can on cause and effect of human papillomavirus and whether it is, you know, affecting the prostate. But in my knowledge to now, please correct me if I'm wrong if you find anything, but prostate cancer is not related to human papillomavirus.
Just a follow-up here from Deborah, but it also touched on something that we had talked about off camera, as it were. The GP has said that the bone density scan is unnecessary, but she'll ask her surgeon as well as the oncologist. But how can we get to how can we get a second opinion here in Canada, and how can we go from like, oh, maybe, you know, if my GP says this is unnecessary, how can we go about getting someone else to, or a referral or something like that?
So I find that us here in Canada, we're so stupendously polite that we feel embarrassed and awful about being more adamant and our own advocates, and we have a tendency to feel as if we can't and shouldn't ask for a second opinion. If you were in the States, let me tell you, you would be going for your second opinion. Now, as far as the bone density scan, this is all part of the Canadian guidelines for what screening things are available to you, especially if you've had pelvic radiation. So if you're, I would just go back to the family physician and say, you know, I'm entitled to a bone density scan annually because I had pelvic radiation. I would really appreciate if you would make me a referral. If your family physician isn't going to do it, then go to your gynecologist, who will also be aware, because you remember gynecologists deal with a lot of women who are having pelvic radiation for genitoanal issues. So your gynecologist can refer you, or you phone your oncologists that you dealt with before. But hopefully, you know, your family physician is going to, you know, step up to the plate and give you a referral. It's a bit silly not to. That answers that.
Yeah, no, I think that's a fantastic answer. Thank you. We have a question here. Somebody asking about the UK group regarding pelvic radiation, or a website or resource that we can look up.
So they're called the Pelvic Radiation Disease Association, and their website is prda.org.uk, and they are brilliant, and that will lead you to all the resources that there are. I'd say that in North America we're slowly getting there, but the UK is just streaks ahead of us. They have pelvic radiation disease clinics in various hospitals up and down the country, and it is so bona fide. And remember that many cancers result in pelvic radiation. So prostate, uterine, cervical, rectal, anal, you name it, there are all these things, and the pelvic radiation diseases there's a whole slew of things. And so if you know that you're having these weird and wacky short, medium, long-term effects post-pelvic radiation, and you're feeling stigmatized and isolated and thinking, oh my God, go onto the PRDA website, because the symptoms are huge, from GI tract issues, incontinency, sexual dysfunction, the osteoporosis, the joint pains, you name it. There's a whole gamut of symptoms that they now know are due to the pelvic radiation.
Awesome. Can you just, in case they didn't have a pen or they didn't type it in, can you just repeat the website?
So it's prda.org.uk, and I'm just going to check on, I know that's what it is, but I'm just going to check on my iPhone, prda.org.uk. Yeah. So if everyone's got that, so it's Pelvic Radiation Disease Association, PRDA.org for organization, .uk for United Kingdom, and it's absolutely brilliant.
Excellent.
And I have to also say that the United Kingdom also has phenomenal anal cancer support group through the Macmillan nurses. Absolutely brilliant. They call themselves the Bumlanders, and brilliant. So internationally, there's lots of organizations with help, and also a huge amount of medical professionals internationally dealing with this. I'm a member of the International Anal Neoplasia Society, who deal mainly with the AINs and high resolution anoscopy and things like that, but they're everywhere. Central America, South America, North America, Australia, New Zealand, Europe, United Kingdom. There's so many medical professionals who are really wanting to raise the knowledge of the neoplasia, but they also deal with the anal cancer as well. So huge amount of really helpful support groups out there for professionals and patients.
Awesome. We have one last question before we wrap up here. And this is Judy asking if colorectal and small bowel cancers are from the same genetic cell group or cell makeup. If you can speak to that a little bit.
So I could answer that, but I'm not a medical professional, Judy. So the etiology of a colon adenocarcinoma, a rectal adenocarcinoma, an anal adenocarcinoma. So anal adenocarcinoma has actually a different embryonic etiology than a colorectal adenocarcinoma on the whole. And then when we start getting into the small bowel cancers, we're typically dealing with a different format of cancer, though I'm sure there are some adenocarcinomas, but the small bowel cancers are rarer. They're not uncommon, but they are rarer. And so I'm not going to say that the etiology is the same. No. Again, that is a question for your colorectal surgeon. Can also answer things on small intestine, but the odds are if you have a small intestine cancer, you're being dealt with by somebody else.
Okay. Well, awesome. Thank you. Thank you so much. to everyone for attending our webinar today, and CCSN would like to thank Helene Hutchings for joining us. It was an incredibly insightful presentation, and just thank you for all the work you're doing as well in the cancer community, not just here in Canada, but around the world as well. It's just so fantastic to know that these resources are being made available to more and more people. This is one in a series of webinars we have planned for 2022. Registration information for our next webinar will be coming up soon, so watch your inboxes and social media feeds for that. Just a quick note about email. If you're not seeing our emails in your inbox, please check your spam or junk mail folders, as we use a third-party email service. So please check your spam folders and mark emails from CCSN as safe. Or sometimes, depending on your email client, you might have different tabs where different things go automatically and they might not be going to your primary. Anyway, just make sure that you can see them and add us to your contact list. So that way you can ensure that they'll come straight into your inbox and you can register for upcoming webinars. As always, all of our previous webinars are accessible on demand through our website, www.survivornet.ca/webinars. Yeah, that is it for now. Thank you so much again for attending our webinar. Thank you to Helen for joining us, and we hope that you enjoy the rest of your day.
Thank you for listening.
Bye now.